Our next speaker is going to talk to us about an update on limb salvage. It's Maritz Laubscher.
Thanks, Brian. Brilliant. Okay, so thanks, ladies and gentlemen. I'm going to talk a bit on the decision-making in the mangled limb, advances in the reconstruction of complex injuries, and then on advances in limb lengthening. So when one's faced with a mangled limb, it's a very difficult decision to decide whether we can provide the patient with eventual acceptable level of functioning in an acceptable time frame for the patient. Historically, there's been various scoring systems used, of which the MES is probably the best known. Most of them are not extremely helpful. This scoring system is not exactly new, the Ganga Hospital scoring system by Rajasakaran, but we find it quite helpful. And according to a pro forma, a point is given from 1 to 5 for the injury to the covering structures, and as in skin and fascia, the skeletal structures, the functional tissue, that is muscle, tendon, and nerve, and then points added for comorbid condition under resuscitation and so forth. And a score of 14 and more correlates with failed limb reconstruction and eventual amputation. There's a few historic myths that have been, in the recent literature, been shown not to be true. We were all once taught that initial absence of plantar sensation is an indication for an amputation in a mangled limb. The LEAP study group showed us that more than 50% of people with initial absent plantar sensation recover, and absent plantar sensation initially did not correlate with eventual function. The second myth is that early amputation do better than delayed amputation. From South Africa here, France and Eric have shown that similar functional and psychological results can be achieved in delayed amputation, and the definition of delayed amputation was amputation after at least 6 months of failed limb reconstruction. So the decision between limb salvage and amputation remains a difficult decision based on a variety of factors, and these include the degree of injury, a scoring system if you want, the expertise available, that's both in orthopedic surgery and in plastics, the timeline of a possible reconstruction. There's no point in attempting a 2-year reconstruction if the patient is unable to commit to such a period. Also the amputation options. Of course, you're more likely to perform a below-knee amputation than above-knee amputation. And then also lastly, the access to a good prosthetic service can also influence your decision making. So there's been a lot of advances in our options for the reconstruction of complex injuries. It's been shown that with the use of shortening and even angulation in combination with mostly external fixation, we can decrease the need for especially free flaps and normally get away with either primary closure or at least simple local fasciocutaneous or muscle flaps. With the use of circular fixators, we can achieve high union rates in very complex fractures, not amenable to internal fixation in both the femur and the tibia with a single index procedure. In certain fractures, like in the distal tibia, we've shown that circular fixation can achieve better result than other means of fixation. And when using external fixation in the distal tibia, we've shown that it does better when a foot ring is not used, in other words, allow for early range of motion. More proximal around the knee, the tibial, high energy tibial plateau fracture. These are Schatzker 5 and 6 fractures, do very well with circular fixation option and achieve similar functional result to plating with lower complication rate. The distal femur, it's the opposite though, and the literature shows that conversion from external to internal fixation do better functionally than patients treated definitively with external fixation. When you do convert external fixation to internal fixation, there's a significant increase in sepsis if the fixation overlaps the holes of the initial external fixation. I use this treatment algorithm to reconstruct the bone defects in limb salvage. Defects of between 0 and 2 centimeters, you can really do whatever you want. You can either maintain the gap and do simple bone grafting later, or do an acute shortening. Slightly larger defects do well with acute shortening and simultaneous distant lengthening, or the Masquelet technique or variations thereof. Larger defects, sort of 4 to 8 centimeters, is ideal for bone maintaining length and doing bone transport. Over 8 centimeters, it becomes quite difficult. Bone transport is still an option, but with sleepless nights, both for you and for the patient. And over 12 centimeters, one should always consider an amputation. Bone transport is still an option, but quite difficult, and it's probably the one place for vascularized grafts. So again here, there's some recent evidence that shows us in the tibia acute shortening of up to 4 centimeters has no change in the intraoperative perfusion of the limb. Of course, you can shorten more, especially if you plan to lengthen later, as much as the soft tissue allow really, if you plan to lengthen the limb either at that time or later. In defects, especially in traumatic defects, shortening with simultaneous distal lengthening works very well and has a high success rate. And then there's been various modifications of the original Masquelet technique described with good success. So to show some examples, this is a traumatic bone defect in the distal tibia. After squaring off the ends, there on the left, where you can see the fracture in a temporary external fixation. It's about a 6 centimeter defect treated with acute shortening and simultaneous proximal corticotomy for lengthening. And while the distal fracture unites, you lengthen the patient to give them the length back. And this is at the completion of lengthening, just waiting for the regenerate to beef up, showing a nice regenerate and ongoing union of the distal fracture site. And this cuts down on the healing time compared to maintaining the gap and doing bone transport. An example of the Masquelet technique, or really modification of the Masquelet technique, because Masquelet originally described his technique with the use of external fixation, but since it's been combined with internal, various means of internal fixation. And this is a 6+ bone defect in the femur, treated with a retrograde nail, a cement space that you can see there in the circle, and then later cancellous bone graft with progressive consolidation on serial x-rays. It's really, though, in limb lengthening where there's been massive recent advances in both our ability and our ease of lengthening. And this is with the use of intramedullary nails. And this has really expanded our indications for lengthening, not only for the treatment of leg length discrepancies, can either be post-traumatic or for other causes, also to include stature lengthening. The early generation of lengthening nails were fraught with complications. A Precice nail received FDA approval in 2011, but it's only really been in mainstream use in the last couple of years. The origin of the technology is from the growing rods and spines. And for those that haven't seen it, this is a Precice nail. This is a magnet inside the nail that spins in the external magnetic field. It's a gearbox taking down the resolutions in a 64:1 ratio, driving a threaded bar basically, and lengthening the distraction bolt. This is the external remote control of the rotating magnets that the patient used to lengthen the nail. And it now comes in a variety of sizes, including anterograde, retrograde femur, and tibia. Contraindications are mainly related to the magnet, as well as size restrictions on the leg of the patient. And the potential complications are all really generic complications related to lengthening, specific to the Precice nail. And there's some mechanical complications. In the first generation nails, there were some failures to lengthen as well as mechanical breakage. And the one thing we see quite commonly is backing out of the locking screws, and I'll show you why. We've showed that in femoral lengthening, superior results can be achieved with the use of the Precice nail when compared to external fixation lengthening. So to show a few examples, this is a case of a post-traumatic leg length discrepancy, lengthened with a Precice nail. A nice regenerate there on the right. This is a more extreme case of a patient with neurofibromatosis with previous corrective scoliosis surgery. In essence, she basically had a fixed suprapelvic course of pelvic obliquity, and she had to wear a shoe raise on the right in order to be balanced. So we used the Precice to lengthen her right femur, although it's normal length, to alleviate the need for a shoe raise. And this is her at the end of treatment, standing balanced without a shoe raise. Another apparent leg length discrepancy treated with lengthening. This is a case of a neonatal hip sepsis with an absent hip joint, now in an adolescent or young adult with a severe leg length discrepancy, treated with a retrograde Precice nail, and at the end of treatment, a horizontal pelvis basically, but the right femur in essence longer than the left. There's an example of congenital lengthening. If you just note the dates there of the x-rays, these x-rays are 2 months apart, showing very good regenerate and a very low healing index. So anything under 31 days per centimeter in leg lengthening is considered very, very good healing when it comes to healing index. And this is the same patient 1 month after completion of lengthening with excellent hip and knee range of motion. Of course, as it's easier to lengthen, the indications are expanding to stature lengthening. This is an example of a non-syndromic short stature, in other words, just a short person wanting to be taller, of a femoral lengthening of 8 centimeters bilaterally. An example of syndromic short stature, as in this patient with achondroplasia. Now, when I worked in the UK, the syndromic children are treated, or children with dysplasia are treated from a young age with growth hormones, so they already gain sort of 5 to 10 centimeter height, and then with the Precice lengthening at skeletal maturity, they can have near normal height. Retrograde femur is also available, and also the tibia, as in this case of post-clubfoot shortening in the tibia. And then, of course, as we achieve good results with simple lengthenings, the indications have also expanded to include acute deformity correction and lengthening with the Precice nail. And this is an example of a congenital short femur with previous lengthening gone wrong, and a deformity as well as shortening, treated with an osteotomy and lengthening with a Precice nail through the osteotomy site. Slight intraoperative complication of perforation of the anterior cortex that was bypassed with the nail, but uneventful lengthening to correct the leg length discrepancy. Another case of simultaneous correction, this time in the distal femur, intra-op with the use of a temporary frame to correct the angulation before insertion of the Precice nail for the lengthening. And good results post-lengthening. The last case here, just to show some of the unique challenges we encounter in South Africa, limb reconstruction. This is a young boy with a congenital short femur that 4 centimeters into a planned 6 centimeter lengthening, while in an overcrowded taxi on his way to the hospital for outpatient follow-up, the taxi rolled and he unfortunately bent his Precice nail. Now, when I worked in the UK, every patient undergoing Precice lengthening was transported with hospital transport back and forth to the hospital. Of course, we don't have that, so unfortunately we had to, of course, the lengthening mechanism ceased, so we couldn't continue to lengthen, and we had to convert to a normal nail leaving him 2 centimeters short of the planned lengthening. Of course, there can't just be benefits to the Precice. The main downside is cost. The nail is extremely expensive. Just remember, it's not in comparison to nothing, and the standard setup for a rail lengthening in the femur is about 70,000 Rand, plus some of the extra costs in the Precice will be offset by less need for fewer complications, less need for revision surgery, and so forth. Thank you very much.
Thanks, Maritz. Before we call Sitombo up, I've got a few minutes that we can address some questions, if you have 2 Maritz. Sorry, we can see nothing from here, so no questions. Everybody, a question at the back? Yeah. Sorry, Mark.
Is it okay? Just regarding the Precice intramedullary nail for lengthening, the cost is a significant factor here in South Africa. In fact, Discovery Health are adamant that they will not pay for a Precice nail. They've yet to fund one, and because they are now administering many other medical aids, the other medical aids are following suit. The only people that I know, I've had foreign insurances pay for the Precice nail, and the workman's compensation is paid. But I don't know if anybody else in the audience has had any of the more conventional medical aids in South Africa pay for it. But at the moment, they say there's no evidence, and they refuse to pay. Any comments on that?
Yeah, no, unfortunately, it is a huge issue. I'm not sure whether we'll be able to convince the funders to pay for it. The cases we've done have been in the military, workers' compensation, road accident fund. I haven't managed to get a funder to pay for it, or self-fund it for patients. So I haven't had a funder pay for it. Look, we would hope that by some more evidence emerging of it being superior, that we might be able to, but I'm not sure whether we'll get any funders to pay for it. Dr. Roddison, yes?
Brian, thanks for the talk, very enlightening. Just a comment about when we're comparing 2 groups, one that gets fixed initially and another one that gets delayed, and they get put in ICU, and then we're using the ICU as a measure of when we compare them. Now, if you put someone, if you delay your fix, you put them in ICU with an X fix on, you tell the guys in ICU you're going to fix him 8 days later when the SIRS is all passed, then isn't it a self-fulfilling prophecy, really, that he's going to be staying longer in ICU anyway? Because the guys are going to keep him ventilated till you're ready. His hospital costs are going to be increased anyway. So I'm not sure if that's a very valid, parameter to use for comparison in a way, when we're looking at the clinical results. Maybe very valid for cost, but I'm not so sure about it. Like I say, I think it's obvious that the guy's going to stay in ICU longer if he's got an X-fix on.
I think you're absolutely right. So if you're keeping your patients in ICU and waiting and monitoring them, you clearly got to, that's the whole point. What they're saying is that, in fact, if you fix them early, if you can adequately or aggressively resuscitate them and get their lactate down, specifically in the first 8 hours, you don't have to keep them in the ICU. You will reduce your complication rate will be less, and then concomitant with that will be less ICU stay, less time in hospital, etc., etc. So I think the two do run hand in hand. Clearly, if you do decide or you do have to do a damage control type of protocol, and I think, Paul, this is all in evolution, which is why it's part of the pendulum swinging. And I think we all practice common sense orthopedics is probably damage control type orthopedics. Obviously, you're going to still fluctuate somewhere in the middle. This is not to say that if you get your lactate down below fall and you've got no chest injury that you have to go and fix everything. Clearly the patient has to be looked at in the clinical as a complete problem. And it's what we've been doing all along. I think that we all do sometimes nail the femur but don't do the tibial plateau at the same time. We wait then 5 days and we come back, and that's kind of common sense. But we've now got some proper parameters that we can utilize to encourage us to go ahead quicker if possible, if logistics allow it, with good outcomes. And I'm sure it will evolve a little bit further. It's just clearly we now have a couple of figures that we can utilize, and lactate is easy to get. You've got it in pH and base excess. You've got it in all hospitals. Interleukin-6 is the other parameter that's apparently very prognostic, but it's not available everywhere and not available rapidly everywhere. So I think that we're just being shown that there's something in between damage control surgery and early total care, which is what we really probably were practicing anyway. Yes, Rob.
Before lengthening, but has things changed now? Is that no longer the protocol? Or are there some other way of assessing it as to whether you might just further aggravate the instability?
Yes, there's definitely a way of assessing it, and yes, you're right, the traditional teaching, and the teaching still is that the hip should be stabilized first, if unstable. A number of these cases, though, the hip is actually so stiff that it doesn't allow further adduction. In other words, when you do your planning views for a pelvic support osteotomy, you do flamingo views, which is a single extance X-ray. And if the pelvis doesn't drop on those views, it means that there must be enough stability for the hip to tolerate the lengthening. So I've been involved in a number of these cases where we successfully lengthened without stabilizing the hip first. But you have to assess and make sure the hip is stable. But in essence, the hip is really just stiff. Some authors advocate that you go and do a release first to allow the valgus proximal femur osteotomy to do a pelvic support, but we feel that's not necessary. So in your initial assessment, if the hip is very stiff in a flamingo view, or clinically there's no Trendelenburg, there's enough stability or stiffness in the hip to tolerate lengthening.
Okay, I think we need to move on now. We have built into the program a sort of a discussion at the end, so if there are any other questions, we can take them then. And certainly the last presentation from us is going to be hopefully to generate some of that debate about the first talk. But to now go to the other spectrum, really, another part, we were trying to find parts of the orthopedic trauma management area where we find you guys are going to be talking from all the other special interest groups about certain joints and injuries, but globally, what else don't we treat well? And